everybody, welcome to the LevelLUP ACARE LevelLUP webinar. We will be talking today about unlocking insights, illuminating the significance of pedigrees in hereditary angioedema. My name is Carolina Vera. I'm a member of the ACARE at the Charité Center in Berlin, and I have the pleasure to introduce today our expert panel, Professor Andreas Recker from the Universitätsmedizin in Lübeck. Then we will be hearing from Gašper from the Ljubljana University and from Dr. Roger Colobran Oriol from the Hospital Universitario de Vall und Universitat Autónoma de Barcelona. Today's objective are to develop the importance of the intricate process of constructing pedigrees for our patients with hereditary angioedema, and also to explore the indispensable role of these pedigrees into the familial patterns of hereditary angioedema and practical strategies to effectively screen our patients. As you can see now, this is our agenda. We will have 3 talks and then at the end, a 10-minute question. Right now, we were registered 124 users from all of the 5 continents, which are also ACARE, and ACARE is an angioedema care centers of excellence. We are in all of the continents, and we will continue growing and giving our expertise to help more and more patients with angioedema all over the world. This webinar is also accredited with 1 European CME credits. So if you need the credits and you want to get it, please don't forget to scan this code. We will also share it at the end of the presentation, so you can also get your accreditation. Please leave your comments in the chat so that we will ask our expert panel at the end. Just as a reminder, LevelLUP ACARE is gives us newsletter where we will post all of the activities that are going on in our network. And if you have any questions, please reach out to Julia Vall. There is her email. Stay connected with us with social media. There, if you scan the code, you will find our address to all of our sites, YouTube, Instagram, TikTok, and everywhere where we are to be seen. And thank you again for joining. And with this, I will give the floor to Andreas Recker. Thank you very much.
Thank you. Okay, so I would like to share my screen. Okay, give me a second. This is should be correct. Okay, here we go. Yeah, thank you for this invitation. I think many of you know that the hereditary angioedema typically has an autosomal dominant inheritance. So actually, constructing pedigrees is somehow straight ahead. But I actually took the challenge and tried to find out more special things and things you might find interesting too. And I have a personal focus on hereditary angioedema with normal C1 inhibitor, so therefore the rules are somehow different to what you would expect. So here are my disclosures. And yeah, I will walk you through pedigrees, how you construct them, why you need them, how you typically, or how they are standardized. And yeah, go for some tools, go through inheritance patterns, and finally, I will show you some published pedigrees you might find interesting, because whenever you have something interesting you want to publish, you want to know how to paint that. And the HPO terms is something that became quite important in whole genome and whole exome sequencing, because you can standardize the describe patient symptoms and conditions. So why do you use pedigrees? Yeah, so it's actually a structured documentation of the family history, and you can detect patterns of inheritance. It's also possible to use these pedigrees to for e.g. cancer models like the thyroid risk model for breast cancer, and it's actually useful for input for exome and genome analysis. So standards and patterns. So I will start with the gender. You have males, which are then here painted as a square, females, which are painted as circles. And if you're not sure, or if you have your non-binary person, then you go for this diamond shape. There's sometimes here this AMAB and AFAB. This means assigned male at birth and assigned female at birth and unassigned at birth. Then if you want to go on with painting, you want to show relationships. And relationships are simple. If you have a combination here, pairing of a man and a woman, you have children, then you paint them together, make a line here, line of descent, and then each individual's line. This is a so-called a ship line here. And then if you have something more specific, like divorce here, and you make such two circles here, are these slashes. If you have a consanguinity, then you make two lines. If you have twins and triplets, you can paint it like this with a triangle shape. Either you connect both when you have a monozygotic twins, or you don't. And if you don't know, then you just write a question mark. Then if you have an infection status, you can paint it like this with multiple patterns, but of course you're free to do it as long as it's understandable. And then you go for these patterns. Then you can paint your pedigree, and you want to know what type of inheritance is it. Like here, it's the typical autosomal dominant in HAE. You see that if you have one parent affected, it might have an inheritance of 50% here in this family who inherit that disease. It's going on with each generation. If you have an autosomal recessive state, you have carriers here denoted with a dot in the middle. And if two dots meet and have children, then you have here a 50% chance of getting the disease. X chromosome recessive means that typically males are affected and females are carriers. If you have a complex non-Mendelian inheritance, you don't have this specific pattern. You have something that looks more chaotic. And what's also quite interesting is the mitochondrial inheritance mode. Typically there you have only inheritance by females. So if you have a mother who's affected, then you will get the disease. If you have a father who's affected, you won't. And it's often seen that the disease or condition gets worse with each generation. So how do you paint that? When you want to publish things, you want not only to paint it by hand, so you can use online tools like this Progeny. You can, of course, pay it, but there's a free version. Same with BioRender. BioRender is also used for a lot of these figures that are typically used in life sciences. PowerPoint has the problem that you have a bad resolution when you export TIFF images. This has something to do with patent rights, so therefore it won't have this nice resolution. You can try with PDFs and then transfer it in a different format coming up from the PDF. I personally like R. You can use Kinship too, Pet Tools, Pet Builder to paint it, Python, Pedigree Draw. TXZ is for LaTeX guys, and if I want to draw something freely, then it's OpenOffice or LibreOffice, which doesn't have this problem with exporting high resolutions. This here is a typical way how it is done in R. You see here such a table. You see here IDs, and then the mother ID, father ID is coded like this. Then you need all these orders. The point is you typically can find it in documentations. So if you're familiar with R, you know what to do with S. And then you finally get such a figure. If you work with Progeny, it's very fast, but it's very difficult to adapt in the free version. So you can, in the commercial version, you have even the chance to do it more elaborately, and you can even go for these risk scores. In publications, I just selected some publications where we find interesting pedigrees, and here you find the pedigrees drawn by Conrad Borg and colleagues about the plasminogen gene. You see here, of course, the typical pedigree, and then comments below these individuals. You have all these comments, and here's the legend what this comments mean. Like the first 01 means that you have this RS14224 TC variant. And other people do it like this. They just make here a kind of indicator, an ID, and then combine a table. Here you see something interesting. This is then autosomal recessive inheritance mode. Here you see that there are people from the same family with the same mutation, only the combination here is important. When you have the two pathogenic haplotypes, you have hereditary angioedema type 1. If you have just one, you're more prone to have hereditary angioedema type 2. And if you have none of those, you go for something normal. And it's not given that if you have the pathogenic mutation that you will always suffer from the disease. This is another way how you can paint it. You just use colors. Here they combined the F12 mutations and plasmid gene mutation by Hinze Stefan et al. And they used here this color coding to depict normal condition and pathogenic conditions. This is a pedigree I painted. It's quite simplified. And I just wrote here that the mutation is found in this person, but not that it's heterozygous and not homozygous. So this was not important actually in this case. So here then you can explain it in the legend. And yeah, the last thing is the human phenotype ontology. This is something you use if you want to do whole exome sequencing or whole genome sequencing in a way with some kind of hypothesis-free approach, but not completely hypothesis-free. So you have a clinical picture, symptoms, and then you want to encode that. And these codes are then used by bioinformatics systems to actually extract and interpret the findings of whole exome sequencing. Whole exome sequences always gives you a lot of mutations, all sometimes difficult to interpret. Sometimes they are dangerous, and if you see them, oh, then it's critical, and you see a next step. Okay, you just need to have a homozygous variant of a certain mutation to be critical. So you have a lot of errors in our genomes that are unimportant, and you want to see find out which one is the important one. So you use the HPO term, and it has so-called hierarchical systems. So if you want, for example, encode tongue edema, then this is here in the tree. It's going from all the phenotypic abnormality. Then you go for the head and neck abnormality, here down neck or head, the face, the mouth, the tongue, and then tongue edema. You can also encode neoplasms of the tongue and physiology, morphology, whatever you like. And if you use a system, if you have a gene which is associated, for example, with tongue edema and encode phenotypic abnormality, then it might be possible that you find this one too. Although you have to be careful to be as specific as possible and unspecific as possible too. One way to do that is this tool here. You find it when you go for JAX. Then you can go here, search, for example, for hereditary angioedema. Then you find here the alpha code. And if you look for annotation, you can you find all these stuff like abnormality of the genitourinary system, all these terms that are important for this disease, and you can click on them, collect them, and then if you have here the patient's features, you go for the diagnosis. So, and then it says, oh, you have your angioedema, maybe you have a connection to effector 12. And these are the genes that are filtered away by the algorithm that's used here. Of course, there are several other algorithms in use. So coming to the summary, pedigrees are actually essential in genetic diseases, and you have free tools that are available for drawing professional pedigrees, but the annotation can be really challenging. And as you see, as I already demonstrated, there are several ways how to do that. And some of these ways are maybe not so much space consuming when you have a publication, want to make many subpanels, but it can be difficult to interpret if you don't write all things at one place. Yeah, I recommend to use and to learn how to use HPO terms to maybe also annotate pedigree data and improve the bioinformatic analysis. Okay, so I was quite fast. The questions are later, so I can give on to the next step.
Thank you, Andreas. It was a great talk. Yeah, questions will be held at the end. Now I would like to invite Gašper to give us his talks about new screening, genetics new screening, newborn screening. Please.
Hello. I hope my presentation is sharing now. Perfect. Okay, thank you. So thank you for inviting me. Thank you for the opportunity. I'm not a clinical geneticist and not even a geneticist. I'm a clinical immunologist. So I'm a medical doctor who's taking care of patients with inborn errors of immunity and pediatric patients of inborn errors of immunity. And I'm also, I come from Slovenia, where we have started this year the newborn screening program on inborn errors of immunity, and I'm the head of this program. So I had a long thought, what should I talk in this webinar, and I have decided to share some insights about emerging novel newborn screening that is happening in last years, and that it will become available in the next decade, and some thoughts about whether hereditary angioedema should be one of the diseases that should be also tested with this novel newborn screening program. So these are my disclosures. Just to get everyone on the same page, newborn screening is a public health system that identifies conditions that can affect children's long-term health and survival. It's really important to detect diseases before they appear. So early detection, early diagnosis before the disease can cause damage. And this can prevent death, this can prevent disability, and enable children to reach their full potential. And this is done only by a small sample of the blood from newborn's heel, which is done in the maternity hospital the second or third day after the birth. Just a short history. Newborn screening started in 1960s with pivotal work of Robert Guthries. He started the newborn screening on the phenylketonuria in 1963, and at the end of this decade, the whole America was screening for the phenylketonuria, and it spread around the world. Traditional newborn screening that emerged out of that was that with one test, we can detect one disease, such as phenylketonuria, congenital hypothyroidism. But now with development of the novel methods like tandem mass spectroscopy or PCR, or real-time PCR, the modern ways of dealing the newborn screening is that with one test, we can detect multiple diseases. We can detect several different inborn errors of metabolism, several endocrine disorders, hemoglobinopathies, recently spinal muscular atrophy was added, and immunodeficiencies, and now cystic fibrosis, and even for some inborn infections are screened with newborn screening, such as CMV or HIV. How do we decide which diseases should we include to the newborn screening? This was had a great thought into it, and already in the 60s, Wilson and Younger has compiled the screening criteria for the diseases that should be included later in the newborn screening. But this was the thought that was at that time. These are still important issues. So the diseases that would be included in newborn screening should be an important health problem, should have accepted treatment. So we don't want to screen for diseases where we cannot do nothing with them. The health system should have the available facilities for diagnosis and for treatment. And this disease, the diseases that we would screen should have the recognizable early symptomatic stage. There should be suitable tests available, and this screening would need to be acceptable for the wide population. It's quite important that we would know quite well what is the natural history of the condition. This should be quite well understood, and all of the policymaker or the whole society should agree that this would be suitable. The disease would be suitable for screening and diagnosis. And of course, there were some economical aspects on screening as well. But in 50 years, the medicine has reached so much. So we have really come to several advances in treatments, which is quite effective with early treatments, such as cochlear implants for the congenital deafness. With severe congenital heart defects, we have like new options for surgical repair. We have a lot of different enzymes which we can replace. We can treat patients with stem cell therapy, with gene therapy, and also we can have some specific genotype-driven individualized therapies. So because of that, the newborn screening is also evolving, and there are thoughts and already some progresses on the testing the diseases with only one test. So that with only one blood sample, we can test all of the diseases. But again, we should be careful here that diseases should be the things that are meaningful. So they have severe clinical course and the disease that we can treat. And how we would achieve that with developing genomic together with proteomic and metabolomic data. So this idea was started to develop already 6-7 years ago, where in America they started Baby Sick project, when they want to provide empirical data about what would genetic testing of the newborns bring to the society, about the risk of the genetic, whole genome genetic sequencing, about the benefits, about the costs of it, and to see whether this can be later implemented in the newborn screening program in next years. The same process started 2 years ago in England, where they have made an appeal that they would start research about diseases that should be included into genetic screening, and they have changed the principle about the diseases a bit to try. So there should be strong evidence that the mutations that are found are the cause of the condition. There should be evidence that the variant itself is the variant that causes the disease, not this is just the variant that is in population. Again, there should be pre-symptomatic early treatment options, and the treatment should lead to improved health and comparing to the children what you would wait for the clinical presentation. And of course, you need to have additional tests to confirming what you would find genetically. And this is for the England system. The diseases that should be screened should be, again, economically available for the whole population. These are some data about the first results of the, when they're trying the genetic screening. So this is from the 2 years ago. This group has tried rapid whole genome sequencing with the babies that were critically ill, that were in intensive care unit, whether because it's when you have a baby with unknown disease in intensive care, there is a wide use of newborn screening that on genome screening that tries to look for the genetic cause of the disease, and they have tried to use this approach in conjunction with the retrospective search of their Guthrie cards, drop spots, and try to do newborn screening on the drop spots and compare the data about the things that they found. So they had a great discussion which disorder should they include, and out of 457 disorders, they have decided some of each disorder was intensely thought of, And regarding this question, they have come up from to 380 disorders that they were screening with the newborn rapid whole genome sequencing. And what they found that out of more than 2,000 critically ill children with suspected genetic diagnosis, they have found 104 diagnoses with newborn screening, rapid whole genome sequencing approach, in comparison of the more diseases that they were finding when they were using whole genome sequencing at the time for getting the diagnosis for these children. But they have also found 15 additional findings that were missed with diagnostic whole genome sequencing. And 15 of these disorders were not detected by the conventional NBS newborn screening programs. So they have concluded out of this data, if newborn screening whole genome sequencing would be applied in these children, the symptoms could be avoided in 7 critically ill children. They wouldn't come to the intensive care unit because of the disease. The disease progression would be mostly avoided in 21 children and partially in 13 children. But there is a caveat. The intervention, so the results from the newborn screening whole genome sequencing should be there for until the day 5, and the intervention should start at that time. So this is a quite early and quite heavy burden to get all these results so quickly out. So how could we apply this to our disease, to hereditary angioedema? Currently, in the last revision, international guidelines, there are only 2 recommendations about early screening of the children with no family disease. So there's a recommendation that when you find one member in the family, all the members should be tested for the family. And the second recommendation is when the known patients with hereditary angioedema have their offspring, they should be tested as soon as possible. But there is a caveat on that. The complement assays, so the protein assays, are inconclusive below the 1 year. And we know, and in the next presentation, we'll hear more about that, the identical mutation in the same genes can have substantially different phenotypes in the hereditary angioedema. So the same mutation does not mean that you would have the same severity of the disease. What is our view on the hereditary angioedema now? So this is the recent review article where they have searched for all the articles from last 60 years about the burden of the hereditary angioedema, that is epidemiological, economical, and humanistic. And out of the data, there is still nearly more than 8% chance that the disease would present with edema in the larynx, and it would cause the asphyxiation and the risk of death. But this is the data that was compiled for the last 60, 70 years. There is still need in hereditary angioedema field that we should detect disease as soon as possible, but we would need to be careful how to approach that. Maybe just a reminder how dangerous the disease, hereditary angioedema disease is. This is the data from the German cohort, but this is historic cohort. So this was done, I think, 5-6 years ago. Out of the quite large cohort, nearly 10% of the patients with hereditary angioedema died because of the laryngeal attack that led to the asphyxiations. And the majority of the patients that have a severe cause of angioedema were the ones that did not know that they have this disease, which is quite for the pediatrician quite confirming that only 1 children among these 70s was the one that had the laryngeal attack. The other patients were patients that are treated with the adults, and so this can show that the disease course is more intense in the adult population. So if you apply the principles that they have built in the English cohort and apply it to the hereditary angioedema, we know that there is strong evidence that genetic causes of hereditary angioedema 1 and 2 are the cause of the disease. There is some data that specific mutations are 100% causative, but again, caveat here is that even if you have the same disease, it does not mean that you would have the same, or the same mutation doesn't mean that you will have the same intensive course of the disease. We know that it's better to know that you have the disease in advance, that you are prepared, that you have your on-demand treatment with you. Regarding early confirmation of genetic mutation that we could find with newborn screening, we are until now not having really a good test that they would confirm functional disease. And until now, even though the treatment is getting broader and broader, there are novel options how to treat the hereditary angioedema. This is still quite pricey disease, and I'm not sure that everyone could afford this disease in every at this time in every country. So just to end, we should be aware that all screening do harm. So nobody wants to know that they have some severe disease when they are born. But some of the screening programs do also some good, and the ones that do more good than harm and are reasonable, these are the screening tests that should be applied to the emerging novel methods that would be available in next couple of years. So as a society, as experts, or we would need to have a great talk with our patients, the great talk with our policymakers to see whether this is the disease that you would want to include in our genetic screening program that will be available in next years. Thank you very much.
Thank you very much, Gašper. Great talk. Now to continue in time and with the program, please, Roger, take the screen.
Perfect. Thank you very much for inviting me to this nice session with my colleagues Andreas and Gašper, who did great talks. So now I would like to do some tips about what to do before and what to expect when a patient has an appointment with a genetic counselor. I think that most of these things are useful for patients and both for physicians who treat this disease. So I'm coming from Vall University Hospital in Barcelona. And in this hospital, I run the immunogenetics area. And I'm mainly involved in the genetic diagnosis of primary immunodeficiencies, hereditary angioedema, and other immune-mediated diseases. So first, just a few basic, let's say, preparatory steps that the patient should do before the appointment with a genetic counselor. First, it's important to gather family medical history about any genetic condition or other diseases, and obviously, specifically, any relevant information about hereditary angioedema clinical symptoms that can be in family members. Obviously, if possible, if you can bring a family tree, I assume it's not possible in most of the cases, it could help to illustrate the relationship, but if not, obviously the genetic counselor can do that. Second is to prepare some personal health information. And in this case, it's important including any past or current medical conditions besides hereditary angioedema, because some diseases can be overlapping, and it's important to know that if other conditions are present. Obviously, if you have undergone any genetic test before, it's important to bring the results to the genetic counselor. Then it's very important to have a list of questions or concerns that you have and you want to ask to the genetic counselor, because during the session, the information that the patient receives can be a little bit overwhelming. So I think it's important to have written down all these questions that the patient want to consult to this genetic counselor. And obviously, the fourth point is to know the reason for the appointment. The visit is because you want to find information about the implication for your family or for your own diagnosis, or you want information for your reproductive planning, or maybe you want to understand your genetic test result, because genetic tests sometimes are challenging for the patients. And I will spend the rest of my talk in giving some clues for the interpretation of these genetic reports. And I would say that there are three main aspects. One is what has been studied? One gene, several genes, the whole genome. This is important to know the implications of the results. Which is the methodology? This is a little bit technical, but I will give you just few general tips. And then which are the results? The results can be negative, positive, but sometimes you find any genetic variant that you don't know exactly the consequence, and it's important to know how to deal with. So obviously, the elements to consider for a genetic study is first the clinical suspicion. This is fundamental, and the physicians here have a main role. But then we have some laboratory tests that can drive you to the different genetic tests. You know, for example, for hereditary angioedema due to C1 inhibitor deficiency, we have the C4 low values and low C1 inhibitor function. And these results lead you to directly study the C1 inhibitor gene, which is called SERPING1. So this is a very direct genetic study. But then in hereditary angioedema with normal C1 inhibitor, we don't have reliable markers to decide which gene can be mutated. So in this case, there are a variety of genes that can cause the disease. This is a timeline of the summary of the different genes associated with hereditary angioedema. So the C1 inhibitor gene, SERPING1, was discovered in 1997. It is the most frequent cause of hereditary angioedema. You know, there are approximately the order of thousands of patients described. Then 10 years later, it was described the factor 12 mutation in a percentage of patients with normal C1 inhibitor hereditary angioedema. And I would say that there are hundreds of patients described. And then from 2018, different novel genes have been described: angiopoietin, plasminogen, kininogen, myoferlin, and this gene involved in the heparan sulfate biosynthesis. And some of the genes have been described only in single families, so very few patients described, except plasminogen, in which I would say dozens of patients have been reported. All these genetic defects have an autosomal dominant inheritance. So what about the methodology to address the genetic study? So without giving in full details, we have two different methodologies. One is the direct sequencing, also called Sanger method. This is a very robust method and a little bit time-consuming. This is useful when you have a specific suspicion, so very useful when you suspect about the C1 inhibitor gene, or for F12 or plasminogen that are the second and third most frequent mutations in hereditary angioedema. But then if you have multiple candidate genes, you can do the so-called next generation sequencing technologies. And with these technologies, you can do different types of study. From whole exome sequencing, you sequence all the genome, 100%. Obviously, this is not done in hereditary angioedema as a diagnostic approach. You can do the whole exome sequencing, and in this case, you only sequence the coding regions of all known genes in human genome, and these represent only 1.5% of the whole genome. This approach of whole exome sequencing is not typically done in routine genetic tests in hereditary angioedema, but whole exome sequencing allowed to discover all the known genes, all the novel genes since 2018. You should take into account that the whole genome and whole exome sequencing can give rise to possible incidental findings, so mutations in other genes non-related with angioedema that can be, this information should be acknowledged by the patient, okay? And then we have targeted gene panels. in which you can design a custom panel with containing only the genes that are causing your disease. So in case of hereditary angioedema, you can design a panel including all the genes that so far have been described for hereditary angioedema. Okay, so you have the technology and then you have the results. The results can be positive, can be negative, but let me do some tip about the nomenclature. So we usually say the word mutation, which is good for oral communication. But in the genetic reports, the word mutation is no longer used. Instead, the American College of Medical Genetics recommended to use the word genetic variant. There are several reasons. One of them is that historically, the mutations have a negative connotation. And in fact, not all mutations are disease-causing. Otherwise, most of the mutations are neutral or even beneficial. So we are humans and not primates, thanks to the mutations. So anyway, it was decided that the word genetic variant is more objective and descriptive of any genetic variation. And then when you find a genetic variant, you have to put, let's say, a surname or a tag to define the consequence of the genetic variant. There are 5 possible tags, which is pathogenic, likely pathogenic, benign, likely benign, or variant of uncertain significance, or VHIR. The idea is that you have to gather all the evidences that are in the literature, in databases, to decide if a variant is pathogenic, likely pathogenic, benign, or likely benign. And there is a fraction of variants in which you have no enough evidences to classify the variant as pathogenic or benign, and then you have this tag of variant of uncertain significance, which in fact is a temporary tag because this variant sooner or later should be reclassified as pathogenic or benign. So now I would like to discuss some key concepts to understand the genetic results. One is the genotype-phenotype correlation. This concept refers to the relation with the mutation that you have and the severity of the disease that you express. So as a general concept, there is no clear genotype-phenotype correlation in hereditary angioedema, meaning that you cannot do assumption based on the mutation you have in terms of if you will develop a more mild or more severe disease. It is true that some studies show that type 1 hereditary angioedema due to C1 inhibitor deficiency, these individuals have lower C1 inhibitor levels and more frequent and severe attacks. And type 2, there is more variability in terms of severity. But these assumptions that are true when you compare groups of patients cannot be done in individual patients. Another concept is the penetrance and expressivity. So the penetrance refers to the probability that a person with a particular genetic defect to develop the disease. The penetrance can be complete or incomplete. And then we have the concept of expressivity that describes the degree of severity of the phenotype in individuals with the same genetic mutation or the same genetic defect. So there are different possibilities. For example, complete penetrance and expressivity does typically not occur in hereditary angioedema. One example in which this occurs could be in my field, the severe combined immunodeficiency in which all patients are affected, so the penetrance is complete, and the expressivity is pretty similar among patients. Variable penetrance occur in hereditary angioedema. In fact, it's typical of F12 defect. In this defect, the penetrance is low in men and it's higher, but still incomplete in women. And even in the hereditary angioedema due to C1 inhibitor deficiency, the penetrance is high or very high, but incomplete. You can find few patients with a mutation that do not have any attack during his life or her life. This is not common, but it could happen. And variable expressivity is typical of hereditary angioedema. So different patients, even with the same mutation, can develop different degree of severity. So variable penetrance and expressivity typically occur in hereditary angioedema. Another concept is that, as Andreas showed, the hereditary angioedema is mainly autosomal dominant, and in most cases, the disease is inherited from a parent. In this case, the extended family study of this branch of the family is recommended. So in this example, if the father is affected, the branch family of the father is recommended to do genetic screening because other members of that branch can be carriers of the mutation and can develop the disease. But sometimes the mutation can be de novo, meaning that the mutation has not been inherited from any of the parents. In this case, the extended family study is not required. And an important thing that could be pretty obvious is that even if the mutation is de novo in the patient can transmit the mutation to offspring. As I told you, this is quite obvious, but some patients think, okay, if I have the disease, but it was not inherited from my parents, maybe I will not transmit the disease. That's not correct. For de novo mutation, the patient is carrier of the mutation and can transmit the mutation to offspring. So in hereditary angioedema by C1 inhibitor deficiency, most of the mutations are inherited, but there are a significant percentage of de novo mutations that could be up to 20 or 25% of the cases. This is a high rate of de novo mutations that has some technical explanations because the C1 inhibitor gene has some repetitive regions that make this gene prone to acquire mutations. So it is not rare that some of your patients will have de novo mutation. Conversely, in hereditary angioedema due to F12 and plasminogen mutations, virtually all patients have inherited mutations. And in fact, these two types of angioedema, almost all the patients have a single recurrent mutation, is what we call in genetics a founder effect, because this mutation arose some centuries ago and was transmitted through the generations to nowadays. In case of hereditary angioedema by C1 inhibitor deficient, there are a lot of mutations because, as I told you, this gene has predisposition to acquire mutations in the whole gene. And finally, just to give a clue about negative results. So imagine a patient that is thinking, okay, my genetic test is negative. Do I still have hereditary angioedema? The answer is yes. If you have the clinical suspicion and the clinical symptoms, you have hereditary angioedema, even you don't have a genetic result. There are some limitations in the sequencing techniques that can explain a negative result. For example, Sanger sequencing and the classic next generation sequencing approaches only sequence the exons and flanking regions of the genes. You know that human genes are composed by exons and introns, and only the exons are part of the protein. So exons and flanking regions, these flanking regions determine this intron removal, are the typical regions that are sequenced. So introns are not typically sequenced. In fact, most of the mutations are located in the exons and in these flanking regions, but it could be genetic mutations in introns. The question is that introns are not routinely sequenced due to a cost-effective approach. You can see here that the introns of the C1 inhibitor gene are 10 times larger than the exons. So this makes a huge effort to sequence the introns and a very difficult interpretation phase to see the variants in these introns. Another thing is that here you can see a figure with all types of mutations described in C1 inhibitor deficiency, and there are up to 8-10% of patients that have large deletions or duplications, meaning that different exons can be duplicated or deleted. These mutations are typically not detected by Sanger sequencing and can be detected by NGS, but it's not easy. So if you have a patient with clear indication of C1 inhibitor deficiency and you obtain a negative results by Sanger sequencing or NGS, you should screen these large deletions or duplications using a technique called MLPA. I will not go into details about the technical aspects, but this technique quantifies the presence of all exons. And you can see here two results of two patients of my hospital, and these patients have a deletion, an heterozygote deletion of the exons 7 and 8 of C1 inhibitor gene, and this patient have a heterozygote deletion of exons 1 and 2 that can be detected by MLPA. Why these large rearrangements are not typically detected by Sanger? I will not go into that, but pretty easy. When we do Sanger sequencing, for example, this is the gene of C1 inhibitor that has 8 exons. We do a PCR amplifying all the exons. In this PCR, we do not discriminate both alleles. the maternal and the paternal one. So we amplify both alleles of all the exons. So in this case, this is a simulation in which a patient have a deletion of exons 3 and 4. When you analyze the sequence of these exons, you can see the perfect sequence with no mutations, because in fact you are looking the wild type gene, because this gene has an autosomal dominant inheritance, meaning that you have a completely wild type allele. And since the Sanger sequence is not quantitative, you cannot detect this complete deletion. So this is my last slide, just to explain different reasons of a negative genetic result. Maybe the genetic mutation has been not identified because it's a challenging mutation, maybe deep intronic, promoter, a complex rearrangement. Maybe the gene causing the hereditary angioedema has not been studied. Some centers only study the SERPING1 gene or the F12 or plasminogen, but most of these novel genes are not studied in some centers, so maybe the mutation is there, although there are few patients of each of these genes. Maybe the gene causing hereditary angioedema has not still been discovered, so novel genes are regularly discovered in the last years. And there is also another possibility, which is hypothetic, that is maybe the patient's angioedema has a complete genetic basis, digenic, oligogenic, polygenic. This is still to be demonstrated, but it is not, we cannot rule out this possibility. Or obviously, maybe the patient's angioedema has not a genetic cause, but this should be deciphered by the clinicians. So thank you. I will stop here, and now we can open the discussion time.
Great talk. Thank you very much. Yeah, just as a reminder, please write in the chat if you have any questions so that I can read it to our experts and have a little bit of a discussion. While we wait for the questions, I will do the first one. If you have, Gašper, you were talking about newborn screening, and patient comes with you. I have a HAE. I'm pregnant right now, and I wanna, when the baby is born, I wanna have the genetic testing. What is your recommendation? Should it be direct at birth, or let's just wait a year, do then the biomarkers in blood, and then do the genetic, or how is it?
So if we already know the familial mutation, this could be done quite easily, and even you don't need to put a needle into the baby. You can use also a cord blood and get the results from the baby from the cord blood. And if we already know the familiar mutation with the patients that have a hereditary angioedema, this is also in the suggestions, and I completely agree with them. It should be done as soon as possible, because there is still a possibility that this baby could have an attack even before the complement assay would confirm the disease. So if we would know that there is a mutation, the same as a disease, we would take care of this baby as though he would have an attack as soon as possible. The problem is if there is no clinical evidence of angioedema in the family, and if you would start with the genetic screening and find some novel mutations or already known mutation, you wouldn't know whether this mutation, if it's not already described and confirmed, is a causative mutation of the disease. So this would bring a lot of anxiety and a lot of decrease the quality of life of the patient. So this is the thing that we would need to think really hard about whether this disease should be screened on a genetic basis or not.
Yeah. Roger or Andreas, do you have any comments about it, or how will you do it, or?
Yeah, just a brief comment about we try to do the genetic test to newborns of an affected patient as soon as possible. Sometimes one thing that concern the parents is how we obtain the sample, because it's a very it's a newborn, and none of the parents want that you use a syringe to take blood. So for us, it's very useful to take just a buccal swab, which is less invasive, and to detect a specific mutation works very well. Even it could work for other more complex tests, but just to confirm a known mutation, a buccal swab or saliva, it's useful for this genetic screening?
Yeah, I think from my perspective, how to organize the swap and the reimbursement structure is always a challenge. When I have patients, I can do genetic testing if I have, it's paragraph 116b, it's a kind of special reimbursement type, and I can do genetics when I have such like this, but it's difficult in children. And what I typically ask is that the pediatricians are doing these buccal swabs to do the genetics as early as possible, but this actually requires me to convince the parents to convince the pediatrician. And this is actually a long way of convincing and always fails. So I typically try to get the patients to my side, but normally it's difficult if I don't have the correct reimbursement. Sending them to the human geneticists would be a second thing, but this requires some kind of engagement by the parents. Mm-hmm. And yeah, I just need to convince people to do things I think are right, but yeah, writing letters, something like this is always challenging.
Yeah, and when you get a positive test, how do you say, okay, we have to look how it goes, because it could be that he doesn't present an attack until he's 7, 8, or 15, and how do you then try to calm down the patients? Hey, it's okay, we will figure it out.
Maybe I start. I actually give the patients the tools for on-demand medications. We don't have long-term medication, I think, until the start of the age of 2. So then we can go on. But the typical recommendation is actually to somehow check the attack intensity and frequency. I think there is still a lot of discussion going on the topic on how early you should start with children. Should they experience their attacks or shouldn't they? Many people say, yes, it's something you always have to observe. The degree of expressivity would recite that. But I don't like this idea to have children having their first attack, maybe a dangerous one. So therefore, yeah, it's not very easy. And the social medicine part is actually that I try not only to somehow get the patient somehow they're on demand medication, but also to have some inclusion support at schools, for example. So this is something important. We have this recognition of this disease burden, and there is something like a mark. It's an age. So when you have people who need help, some assistance maybe at school or other situations, then you can try to have that in a social medicine approach to enable them to get something like this, as for example at school or for home. And I also try to incorporate home care services. It's specialized nursing care that are also very helpful at getting a little more deeper to touch with the families with affected children. And they always have questions, and sometimes they don't ask questions, their physicians, but with the nurses, it's more easy to communicate.
Yeah. Are you able to test for all mutations or just for SERPIN, or how do you, if you cannot test for one, do you send somewhere else, or is that an unmet need right now for most of your centers?
Yeah, this is a good question. So in case of C1 inhibitor deficiency, as I mentioned in my presentation, there is some clear laboratory tests that point to that gene. So in this case, we only do SERPIN G1 gene. But in patients with C1 normal C1 inhibitor, we typically do at the same time the factor 12 and plasminogen mutation, because there are the 2 other defects that have a recurrent mutation that it's easy to test, because you have only to sequence that exon in which the mutation is located. And then if the patient remains negative, we discuss with the clinicians if the suspicion of a genetic defect persists, because the other genes, as I told you, have been described only in single families, at least published. I don't know if there are other patients. So in this case, the approach would be or a panel with all the genes, or then you can do a whole exome sequencing, but I would say that this is more in a, let's say, research context than in a routine diagnostic test. We have included all the new genes in our panel of primary immunodeficiencies, so we can put the patient in that panel. But it is not a clear situation. If go looking for all the genes or stop when you tested SERPING1 or factor 12 or plasminogen. That's my opinion. I don't know my colleagues.
Actually, I would support that. But what I like is here actually the opportunity to have whole genome sequencing in the setting for a Center of Rare Diseases. And this is why I came up with this HPO terms, because this is the center of this. Yeah, it's more experimental. It's actually bench to bedside genetics, and actually it's mostly dependent on how well I'm doing these HPO terms and how well I'm doing the symptomatology and the phenotyping. And what I believe is that we maybe need more phenotyping approaches in the future, because genetics is nice, but as you already heard, there are people who are gene negative or who have different expressivity and have the same mutation. So I think we need something else, maybe even high throughput but for phenotyping.
Yeah. And what about you, Gašper?
We do the same approach as Roger said. So if you'd have a protein assay that would suggest hereditary type 1 or 2, we would just go for SERPING, otherwise all 3 genes. But in the next step, again, yeah, so I'm a clinician, so I need to talk with the geneticists what is available. And unfortunately, in Slovenia, for now, we have a lot of possibilities how to go, and we usually go to the whole genome approach later, and even include some parents if they have similar problems. But these are really rare patients, so we don't come often to those, and we take great care of them. So we would like to come to the bottom of their problems if the problems are really bothersome.
Great. Thank you very much for the discussion, for the great talks, and the time flied away. I will share my screen just the last time to remember everybody to take the time and scan now the QR code. That way it will take you to the feedback form, and you will receive then the certificate for, oh, you cannot see it, sorry. Now you can. This is then the QR code for the receiving the CMA points. Then, just as a short invitation, what is next in ACARE? Next, 9th of January, it will be the 13th webinar from the Make It Different series, and they will be talking about hereditary angioedema in children. Don't miss it. If you join the LevelLUP newsletter, you will get the invitation to register. Then we have one coming up on 27th of March, what we don't want to see in angioedema on steroids, where Professor Maga and Emil are going to be talking about androgens and glucocorticoids in hereditary angioedema, what we don't want to see. Also, an invitation to the GUF, the Global Urticaria Forum. It will be held here in Berlin this December. And there is also an ACARE session coming. We're going to talk about the latest of urticaria and angioedema. And also invite everybody to become a care center. CARE is our chronic angioedema register. And if you have any information or you want more information, you can go to the chronic-angioedema-registry.com. That is the website where all the information is to be found. Also, don't miss the All Things Urticaria podcast, Learning with Thomas Bodgereit. You can also collect the code. It's in all of the podcast platforms. Are about 28 nice episodes with different topics on angioedema, and every 2 weeks a new chapter comes. Really interesting topics. And also then the LevelLUP newsletter, where we put up all the activities, webinars, and all the new projects and clinical trials for our patients. If you have anything or you want to reach out, also ACARE office or direct to Julia. And stay connected with us on social media. Please also scan the QR code and you will take you directly to our linked tree, where you can find all of our social media accounts, Instagram, YouTube, TikTok, and also the websites where we post all of the information. And thank you very much to our sponsors, Takeda and BioCris, that help us go with this series of webinars and activities. Thank you all for joining and wish you a great rest of the day. Bye-bye.
Thank you.
Thank you. Bye-bye.